Okay, thank you so much for joining IPQ Academy's webinar. To each and every one of you, your commitment on a Friday evening is really appreciable. And for those who don't know what is an IPQ Academy, just a small introduction about our academy. So it is a dynamic scientific community and study group led by Tabrika Mohammed, dedicated to educating and training infection preventionists. Our strong focus is promoting CIC certification, which helps IPs to build successful IPC program and design training programs tailored to meet specific requirements. At IPQ Academy, we believe that collaboration is key to advancing infection control practices and promoting patient safety. Our members are experts from various medical and educational backgrounds, and they utilize latest research and evidence-based practices to ensure that our students receive most up-to-date information and skills. So if you're just starting out as infection control or looking to enhance your skill and knowledge, IPQ Academy is your perfect partner. Or you just want to stay with the people in your field, you're most welcome to join us. And for our today's session, we are going to talk about Marburg, whether we are ready or not. So for this, we have our special speaker, esteemed speaker, Dr. Emmanuel. He's a distinguished speaker with a diverse range of expertise in tropical and infectious disease. He currently serves as the chair of the Tropical and Infectious Disease Division at SSMC. He's also the vice president of the Emirates Infectious Disease Society. He holds an adjunct clinical professorship at Khalifa University, where he is involved in teaching and passing his legacy to the next generation of medical professionals. He is also a recognized leader in the fight against sepsis, serving as the president of the African Sepsis Alliance and an executive committee and board member of Global Sepsis Alliance. He didn't stop there. He also authored an award-winning book, From Struggles to Success, which illustrates a 5-step model for turning struggles into success. And this shows how much of a motivational leader he is. He believes that struggles makes a person better, stronger, and more successful. And today, on this World Hand Hygiene Day, I believe that we are going to get invaluable insights and guidance on Marburg virus. We are very happy to have you today with us, Dr. Emmanuel. Over to you.
Thank you very much, Lakshmi, for that very kind introduction. Good evening to everybody on this forum, and thank you for inviting me to speak, especially to Tabrika for inviting me to talk about this topic on this forum. So thank you again. It's really a pleasure to be here on a Friday evening or night to talk about Marburg, and also to co-present with Jennifer, who I work very closely with at Sheikh Shampoo Medical City. Within the infection prevention control team and committee. So we hope we're going to share our insights on preparing for Marburg viral disease, and also experience not only from Abu Dhabi, but also from the UK, where I worked in the Royal Liverpool Hospital. So with that, I'm going to share my slides, and then we can start. I hope you can see my slides there.
Yes, doctor, we can see.
Excellent. So we're going to be talking about Marburg viral disease, and the question is, are we ready? And it seems like never ending with COVID-19, and we're now just going post-pandemic with COVID-19. In between that, we've had monkeypox as an emerging infection, and then Ebola from Uganda, which has just been controlled a couple of months ago, and now we're back with Marburg. So it seems like it's not really, the question isn't whether there's going to be another emerging infection. The question is which one is next. And so we really need to be prepared for all these emerging infections. And we're focusing today on Marburg viral disease. So the objectives of the session I'm going to present before Jennifer is to understand the epidemiology of the current Marburg outbreak in Equatorial Guinea, Tanzania, and the previous outbreaks, and then also understand the characteristics of Marburg viral disease and the modes of transmission, the main components of case management, why research is important for new therapies and vaccination, and also then we'll focus on emergency preparedness and what we should all be doing within our healthcare facilities, and perhaps also within the region and country. So why should you be concerned about Marburg viral disease in 2023? I know most of you, if not all, are infection preventionists, and I'm sure you are the people in your hospitals waving the flag and putting your hands up and waving, saying, people, you should really be aware of this, you should be prepared. So I may be preaching to the converted here, but it's really important that we should be prepared. The reason is because in February, 13th of February 2023, the Equatorial Guinea health authorities declared an outbreak of Marburg viral disease. And since then, they've reported a total of 40 cases. And this is up-to-date data. 40 cases reported so far. Unfortunately, majority have died. There have been 17 confirmed cases, not laboratory confirmed cases, and out of those 17, 12 deaths. So in terms of case fatality, based on the confirmed cases, it's 70.5% case fatality. And this is not only unusual with Marburg disease, and that's why we worry about Marburg, because there are reports of case fatality rates of 20 to more than 80%. So this is just an illustration of the typical case fatality. So a total of 40 cases. There have also been 23 probable cases, all of whom have died before a laboratory diagnosis. So they were presumed to be cases of Marburg viral disease. Now, the cases in the Equatorial Guinea are in an area called the Bata district in the northwest of Equatorial Guinea in West Africa, and in a province called in the Littoral province. And it's the area, Bata district, is quite an urban concentrated area. And when you have a viral hemorrhagic fever outbreak in an urban area, it's always a really, really serious situation, because the risk of escalation is quite high given the dense population in the urban areas. There have also been reported cases in three other districts, but the majority is in the Bata district, which is the economic capital of Equatorial Guinea, and therefore quite urban. So that's why we're worried. And the main outbreak is Equatorial Guinea. And unfortunately, there are still new cases being identified. So the outbreak is not yet under control in Equatorial Guinea. Now, in Tanzania, it's a different situation. They reported an outbreak on the 21st of March 2023. The two outbreaks in Tanzania and Equatorial Guinea are actually unrelated. It's just coincidence that they are happening at a similar period, but it wasn't because of transmission from Equatorial Guinea to Tanzania. They just started at different times, similar periods. In Tanzania, there have been 9 cases so far, 6 deaths, and most of the cases have been in the northwest of the country, in the Bukuba rural district in Kagera region. Because of that, there have been hundreds of contacts that have been kept under monitoring, and thankfully, 211 of them have already been released after more than 21 days of quarantine. So we're hoping that with Tanzania, very soon, they will be declaring the outbreak under control if they have no further cases by the end of this month, which is 42 days since they last discovered a case, as per WHO definition, when they can close a viral hemorrhagic fever outbreak. So the situation in Tanzania is looking good, in Equatorial Guinea less so. So, but why should we be worried about travel about it in the Middle East? Well, this is an example from Dubai, which just shows that in Dubai, because of the travel, frequent travel destination, not only because of flights and transit flights, but because of it being a frequent destination for holidays. And this is data from last year, 2022, with close to 30,000 flights. And this year, this is much more flights per month, more than 100 countries. People come from 100 countries visiting a place like Dubai. And so the risk of viral hemorrhagic fever moving from a place like in West Africa or East Africa to the Middle East, especially UAE and Dubai, is quite high. The same applies for Abu Dhabi, where we are currently in our hospital. So with travel, any illness, any infection or outbreak happening in one part of the world can easily get to another part of the world. And this is just an illustration. You can apply the same for Qatar, you can apply the same for Saudi Arabia, also a lot of travel, and Kuwait, etc. So viral hemorrhagic fevers, the main Ebola and Marburg sit within the family of filoviruses, or string-like viruses. Philo meaning string-like, so they're filoviruses. And the two main ones is Ebola and Marburg. The Liouville virus is a zoonosis. It's transmitted similarly, has a potential to be transmitted from bats to man, but there have been no reports of transmission so far. So it's been identified in bats in Spain, but no evidence of transmission from bats to man. So the main ones where there have been transmission from animals to man, bats to man, is Ebola and Marburg. So within the filovirus family, the main ones to remember is Ebola and Marburg. And these are very similar infections of viral hemorrhagic fevers. And so we tend not to even differentiate them. And now the WHO just refers to both of them as filovirus hemorrhagic fevers, because the management and infection control principles are nearly the same. So how is it transmitted, or how do you get an outbreak? These viruses are zoonosis. So they're transmitted from bats, specific types of bats, then transmitted to humans, to animals, such as chimpanzees, monkeys, or other animals. And then man gets in contact with the chimpanzee or monkey, either through hunting or just through close contact, or directly from the bat to the human, get infected, become ill, then there's transmission because it's highly infectious, and amplification from human to human transmission, leading to an outbreak. And that applies to Ebola, just like it applies to Marburg disease. And that is how transmission happens. You have initially infection from bats to human, or from monkeys or apes to human through hunting, eating meat, etc., straight then to infection in the human, and then transmission amongst humans, amplification. So what's the history of Marburg viral disease? The first thing to mention is it was first discovered in 1967 from Germany, in Marburg, hence the word Marburg disease. It was transmitted by a monkey that was transported from Uganda to Germany for research, and then subsequently caused an outbreak there. But first discovered in 1967 during that outbreak in Germany, Marburg, in a town called Marburg, hence the name of the virus. The largest outbreak, however, has been in Angola in 2005, where there were 374 cases, and unfortunately close to 90% deaths in Angola. The most recent one before the current outbreak was in Ghana, West Africa, where there were 3 cases with 2 deaths. As you see here, the case fatality rate varies very, very much, but it goes up to 100% case fatality rate, so quite high case fatality rates, typically 70 to 80%. There have been also cases reported in non-endemic areas out of West or Central or East Africa, in parts such as South Africa, in the Netherlands, for example, but this is mainly from travelers, people who have traveled to these areas, been in contact with Marburg viral disease through contact with bats, or by visiting caves, and then gone back after holiday, and then developed Marburg viral disease. So how is it transmitted? The main means of transmission initially from animal to human is by close contact, either a human being going into a cave or a mine which is inhabited with specific bats, the Egyptian fruit bats, and then direct contact or indirect contact with the bats, secretions from the bats. Then transmission from wild animals, from bats to wild animals, then man becoming in contact with the wild animals, such as the monkey or gorilla that is already infected with the virus. In terms of human to human transmission, this transmission is by direct contact with bodily fluids, any type of bodily fluids, whether it's vomitus, blood, urine, saliva, etc., from a person who was already sick with Marburg viral disease. As well as direct contact with bodily fluids, there is also indirect contact where there's contaminated surfaces or equipment, and then you get in contact with the secretions, touch the secretions on the equipment or surfaces, and then carry that to your mucosa or skin. The other way is quite common in West Africa is people who prepare deceased people, so dead bodies. And so either traditional healers or who are preparing deceased persons' bodies may then get exposed to Marburg viral disease. There's also reports of secondary transmission after recovery from Marburg viral disease because it can continue to be excreted in the semen. And so that's why men who develop Marburg viral disease are asked to have protected sex for at least 12 months after recovery from the illness because of the risk of still passing the infection to other people sexually, because it can still be detected in semen up to 12 months in some cases after the infection. So that is how you transmit Marburg viral disease. So the people at risk related to the transmission are people who visit mines or caves with fruit bats, Egyptian fruit bats, people who are in contact with other sick people with the illness, such as healthcare workers, family and friends, laboratory workers in contact with specimens from a patient that has Marburg viral disease, or people handling dead bodies, people who have died from Marburg viral disease, and also traditional healers, especially caring for patients who have Marburg viral disease in an endemic area. So what about, how does it cause illness? It causes illness very similar to Ebola, and it's similar to sepsis. So the virus enters your body through a break in your skin or mucosa. It then disseminates to your reticular endothelial cells, your system, and causes necrosis and intense inflammation with release of cytokines, which cause inflammation. And then it behaves just like a sepsis-like illness with coagulopathy, shock, vasodilation, and just very similar to shock. So what are the signs and symptoms? So the incubation period is 21 days, up to 21 days, and that's the most really important to remember. Anybody who has risk factors and is within 21 days is really the cutoff when you should be thinking of viral hemorrhagic fever. If the illness started more than 21 days after exposure, then it is not going to be Marburg viral disease or Ebola viral disease. The first symptoms are an abrupt high fever. It behaves just like any viral infection, just like COVID or flu, headache, malaise, muscle pain, muscle ache, and then later on, it's followed by severe diarrhea, abdominal pain, cramping, nausea, and vomiting, followed by bleeding from any site, whether it's nose, eyes, gums, vomiting, or rectal bleeding, and then followed by encephalopathy with confusion, irritability, aggressiveness, and then it then becomes fatal. So when the people start having gastrointestinal symptoms or encephalopathy or bleeding, it tends to be a bad sign. So early signs are just like any viral illness. Then late signs are gastrointestinal with confusion, encephalopathy, seizures, or shock. In terms of laboratory findings, you tend to have, because of the vomiting, diarrhea, and fluid loss, a lot of electrolyte imbalance, acute kidney injury. They'll have a low white cell count because viral illnesses tend to cause a leukopenia, and then a thrombocytopenia with a low platelet count and abnormal liver function tests with disseminated intravascular coagulation. So abnormal clotting, which then leads to the low platelet count with abnormal clotting leads to the bleeding. So coagulopathy tends to be a late feature, but it's actually not common. It's serious when it happens and it's a late feature, but in Ebola viral disease and Marburg viral disease, it happens in less than 30% of cases. And so hence why we no longer refer to these as Marburg viral hemorrhagic fever, but more as Marburg viral disease. And the same with Ebola. we now have to refer to it as Ebola viral disease, not Ebola viral hemorrhagic fever. So the symptoms are non-specific, and somebody coming back from West Africa with malaria can potentially behave just like somebody with Marburg viral disease. Other illnesses like yellow fever, typhoid fever will behave exactly the same. So it's very difficult to differentiate just based on history. That's why the 21-day incubation period is so important. So you have to also take a detailed history of exposure. Has the person visited mines or caves or been in contact with somebody suspected or with a probable illness in keeping with Marburg viral disease? So you need to also ask yourself, within your emergency department, is taking a history of travel for somebody presenting there acutely unwell, is it routinely done? If your emergency department is not doing this routinely, they would easily miss a patient with Marburg viral disease. The travel history is so important, as well as contact with people who are potentially ill. The diagnosis is with reverse transcriptase PCR. It's an RNA virus. And so it's RT-PCR that is the mainstay of diagnosis, and it's the most sensitive and specific test. There are also antigen tests, ELISA antigen tests that are available, and they're less sensitive. The other methods of detecting the virus through culture or electron microscopy or by histochemistry are possible, but they are very intensive, expensive, and are done in biosafety level 4 facilities and not commonly available. So diagnosis is mainly through specialist laboratories, reference surveillance laboratories that can do RT-PCR or ELISA. Caring for patients with Marburg viral disease, the treatment, unfortunately, is only symptomatic. However, if you do the symptomatic management well, survival increases, and that involves early aggressive fluid therapy, correcting clotting, correcting electrolyte imbalance, painkillers, managing fever, and potentially giving antibiotics or antimalarials if there is suspicion of co-infection. So treatment is symptomatic. Unfortunately, there's no specific treatment for Marburg viral disease. There is for Ebola, but there isn't for Marburg at the moment. There are some treatments that are being tried, antivirals and also monoclonal antibodies, but they are not yet licensed or approved, and the effectiveness is still very uncertain. So within the outbreaks especially outbreaks in Equatorial Guinea, there are trials ongoing with antivirals and also monoclonal antibodies, some of which I've mentioned here. And that's very different from Ebola. Now with Ebola and the large outbreak we had in West Africa around a decade ago, we have treatments for Ebola with monoclonal antibodies that reduce mortality by around 50%. We don't have that for Marburg viral disease. We don't also have a vaccine for Marburg viral disease, unfortunately. There are vaccines that are in development, such as this Johnson & Johnson vaccine, and the other vaccine which I mentioned here is on the phase 1 trial. But Ebola, thankfully, we have 2 vaccines licensed for Ebola, for pre-exposure prophylaxis as well as post-exposure prophylaxis with Ebola. But Marburg, we don't have one. And that's why we're so worried about Marburg. High mortality, high risk, and no treatment, specific treatment, no vaccine yet. And that brings me to the topic of high consequence infectious diseases. Monkeypox, Ebola, Marburg viral disease are high consequence infectious diseases. And in infectious diseases, we treat them differently, and infection prevention control are exactly the same. And high consequence infectious diseases, or HCIDs, they are an acute infection. They have the ability to spread rapidly in the community or in healthcare setting. They have high mortality, and Marburg fits that. They have difficult in diagnosis unless you have a specialist lab that can do PCR for this virus, and it's not all labs that have it. The effective treatment is lacking, as I've already mentioned in Marburg, and coordination needs really national level coordination to ensure that there's effective and safe and consistent response. So Marburg meets all the criteria for a high consequence infectious disease, and hence why you need to be worried and have special systems to respond to Marburg viral disease. So how do we then prevent infection and what is our role? And the principle of looking after or preparing for Marburg viral disease is we have to protect ourselves so we can save lives. There is no point having healthcare workers jumping in to look after patients with Marburg viral disease when they're not prepared. They're going to expose themselves. You potentially lose staff, and it's unlike COVID. This is mortality of up to 80 to 100%. So you cannot make a mistake with this one. So we have to prepare ourselves so we protect ourselves in order to save lives. If you don't do that, you lose healthcare workers, unfortunately, as we did during the COVID outbreak, and then we struggle to run the service and save lives. So the things to remember is to prepare, you need to know your epidemiology. So as I said, I'm repeating this, incubation period up to 21 days. So all your staff should know this, 21 days. They should know where the outbreak is. And travel history should be routine in your accident emergency department so that they can then figure out whether somebody who's coming unwell has traveled to an outbreak area, such as Tanzania or Equatorial Guinea, and are ill within 21 days. And then ascertaining whether they have exposure to blood or any body fluid from a known or suspected patient, and then whether they fall within a risk group, such as family members, healthcare workers, caretakers, traditional healers that have been in contact with somebody who may have Marburg viral disease, or contact with animals or bushmeat, for example, either through hunting or they've been to a cave or mine where they're likely to be bats infected with Marburg viral disease in an endemic area. So in terms of preparedness, the first thing you need to do is to be prepared to identify and safely manage a potential case of Marburg viral hemorrhagic fever or Marburg viral disease in your hospital. So you need to be able to identify, your staff should be able to identify the patient by taking a travel history or a history of travel to an endemic area within 21 days. And that's a patient with an acute infection. Then they should be able to isolate that patient rapidly in a negative pressure room with correct PPE, which Jennifer will cover. And then alert the right people, infection prevention control, infectious disease, local infectious disease team or unit if they've got one, and then the Department of Health notification so that they can be wider interventions to control potential spread. And then manage the patient as much as they can to save their life, but minimize exposure, whilst also discussing potential transfer to a more secure, high consequence infectious disease unit. So this is what we have as our own pathway, which we developed for Ebola, infection prevention control team, our infectious disease team, and stakeholders within Sheikh Shahbud Medical City. Just an example of our Ebola viral hemorrhagic viral disease pathway. We're now working on converting that to a viral hemorrhagic fever pathway, which involves Crimean Congo hemorrhagic fever, CCHF, Ebola, and Marburg, so that it encompasses management of all potential viral hemorrhagic fevers as a pathway, because often it's very difficult to differentiate. And the infection prevention core principles and management are very similar, very, very similar. And so we are now producing, we're just about to complete producing our own pathway. And that describes exactly what should be done in our hospital step by step. So if anybody doesn't know what to do, they just need to pick up this pathway available via our intranet and follow it step by step. And by doing this, we'll be able to safely manage a patient within our hospital with suspected viral hemorrhagic fever. So safe clinical management, I want to just focus a bit on this, is to safely manage suspect patients, you need people who are highly skilled, especially when you've got a patient that's very likely to have the infection. If they're going to stay within your hospital, you need probably a small number of highly skilled staff that are going to look after this patient until the patient is moved elsewhere or improved and de-isolated. The second principle is you do not request unnecessary investigations. If you do that, you're just going to expose your staff and laboratory to potential transmission. So management of patients with high consequence infectious diseases is based on using clinical acumen. This is where you drop investigations and you use your clinical acumen. You only do investigations that are likely to significantly change your management. If they're not going to change your management, you just use examination. You look at your patient, they're dehydrated, you give them fluids and reassess. You don't need UNEs to do that. You avoid necessary face-to-face interactions also. And often in a high consequence infectious diseases unit, and when looking after such patients, we will plan as a team who will go in. So in the morning, for example, nurse will go in, they'll do everything and give the patient food. In the afternoon, it may be the physician going in to see the patient, and the physician will go in and also do the rest. So physician will even go and do observations and take the food in to the patient. So you don't get a nurse going in to see the patient every few hours. So we cluster care. So the teams are functional and plan who is going to go in to see the patient at certain times. We also use a telemedicine, so it limits the amount of time you need to go in to see the patient and increase the risk of exposure. And you use your clinical acumen, and we may treat empirically. If we think they may have malaria, we'll treat them for malaria without a test. If we think they need antibiotics, we'll treat them with broad spectrum antibiotics and reassess later. And that's really how we minimize the risk of exposure, but also improve the outcome of the patient. So the key preparatory steps recommended with you need to educate your staff, brief them either face-to-face or by email or meetings, or through rounding. You form a multidisciplinary group to prepare, develop a pathway which takes you from arrival of the patient right to safe transfer, including what happens if they become critically ill and need to be managed in your critical care unit. And you also do dry runs, learn from the lesson, and then continue to refine. And that is how you prepare your facility. And this is what we've been doing regularly at Sheikh Shahabud Medical City, making sure our staff know about viral hemorrhagic fever, specifically Marburg in this case, and the current outbreak. We have a multidisciplinary group that meets and discusses what we need to do, develop a pathway also, which we've developed and disseminate with, and use that to educate staff. And then we do also have done dry runs to test our systems. So the ideal case scenario for a healthcare system is to have high consequence infectious disease units, perhaps in different parts of the country, where they don't only receive people who have confirmed viral hemorrhagic fever like Marburg, but even suspected. So if you have somebody in a private hospital or a government hospital with suspected Marburg viral disease, they can keep them in isolation until they are transferred. This system will remove the risk of errors in other healthcare facilities, such as private healthcare facilities that may tend to be less prepared than government health facilities. And ideally, for example, in the UK, we have three designated high consequence infectious disease units in the UK, in England. And similarly, in the UAE, Al-Rakba and also Al-Ain Hospital are designated as isolation hospital. But these units need to be staffed and set up to receive safely and treat patients with high consequence infectious diseases. And they have to be staffed adequately with the right number of nurses, infectious disease physicians, and other specialties that they would need to look after a patient with high consequence infectious diseases. So they do need funding. These units also are set up to prepare. They provide training for other staff and units, and also prepare for research. So if they have a patient or an outbreak, then they can also do research to answer some of the questions that aren't answered about specific high consequence infectious diseases. And so we shouldn't wait for an incident before we prepare. I would strongly advocate for each country to prepare a system to deal with high consequence infectious diseases. And I would say the system in England is a very tried and tested one. And other countries may want to look at that system. So the take-home message, and as I conclude, is Marburg viral disease is an important high consequence infectious disease that requires consideration at any setting. We need to be prepared. It is easily susceptible to robust IPC measures if you do the right thing, but you need to be prepared. Your staff need to be prepared. It mimics many other tropical diseases, and so you need to know your epidemiology and make sure your staff are prepared to identify a patient with potential Marburg disease, isolate the patient, safely manage that patient, alert the right people, and then either have a decision about treating the patient on site or transferring to a designated high consequence infectious disease unit. And I'll stop there and thank the infection prevention team at Sheikh Shahabud Medical City, the excellent team that I have the privilege of working closely with to keep our staff, patients, and visitors safe at Sheikh Shahabud Medical City. Thank you. for inviting me, and thank you for listening.
Thank you so much, Dr. Emmanuel. That was a very insightful session. So we will move to the part 2. So we have our speaker, Ms. Jennifer De Quito. She's an experienced infection preventionist with a strong background in nursing and infection control. She's been working in the healthcare for over 2 decades, and she started in Marburg in 2006 as staff nurse and became a link nurse and started working as full-time infection control nurse from 2018. In addition, she is also a certified infection control nurse from CBIC, and she is a valued member of several task force, including surgical site, COUTI, and CLAPSI task force in SSMC. And she is the coordinator for infection prevention and control link ancillary program. Over to you, Jennifer.
Hi, good evening to all. Thank you very much for the good introduction. And thank you, Dr. Emmanuel, for allowing me to be your co-host speaker for tonight's event and for the organizer of this subcommittee. So before I will share to you my screen. Can you see my screen? Yeah.
Yes, we can see.
So, as Dr. Emmanuel already discussed, that this Marburg disease is high mortality and no treatment for this one. So we have to make sure that we are aware and we should practice meticulous infection control measure to protect our staff and all other patients for this Marburg virus. So the objective of my presentation is to emphasize the importance of training, practice, competency, use of trained observer to ensure the safety in donning and doffing process of the level 4 PPE, review safe handling and proper placement of the patient, discuss the proper waste management, cleaning and disinfection of used equipment and environments. I just want to emphasize to you what we are doing in SSMC to maintain the competency of our staff during the COVID-19. As we all know, all the competency training was stopped or hold during the COVID-19, but our team developed training video so the staff will keep their competency and they can access the video anytime that they need. And we develop also training checklists for them. So if there is patient, we will receive as a query or confirmed case of hemorrhagic fever, our staff are trained and still they are aware of what they will do in case they will handle this patient safely. And also, this video will be played later for you to show to you how this one to don and doff the PPE properly. Sorry. So what is the place where we will keep the patient? As discussed by Dr. Emmanuel, we knows that the patient is already suspected hemorrhagic fever or Marburg disease patient. The patient should be kept in an airborne isolation room with a negative pressure, and the patient should have a surgical mask. Any patient confirmed or suspected case of Marburg virus presented in your facility should be placed directly in the negative pressure room. Visitors are restricted from entering the patient room. Exemption may be considered on case-to-case basis for low-risk patient. Maintain a record of all persons entering the patient room, including visitors. So for the patient transport, SSMC is not the receiving facility for this hemorrhagic fever patient, as mentioned by Dr. Emmanuel. But in our hospital, we have dedicated unit in case that really we need to admit the patient. In case the Al Raba Hospital has full capacity, we dedicate one ICU for critically ill patient and one dedicated medical floor for non-critical patient. So we have already system if the patient needs to be transported from ED to our hospital to the unit. So traffic control shall be done during patient movement. The lift will be dedicated to the patient and escorting staff. The housekeeping staff shall clean and disinfect the lift with recommended chemical soon after the patient transfer. Moreover, the lift shall not be used before cleaning and disinfection. The housekeeping staff wear recommended PPE. This will be the level 3 PPE for cleaning and disinfection. And as you can see on the screen, this is our pathway where we have dedicated elevator already. And this is all communicated to all staff, including security. And we have the process if we receive suspected cases to be admitted in the floor, we need to call the security. And this one is already in place for the safety of other patient and other staff. So for the cleaning and disinfection of the so we have to use hospital approved chlorine-based disinfectant for terminal cleaning. Fumigation should be done after terminal cleaning, and the room should be kept 1 hour for the air circulation. And also you can use quarterly ammonia for the machines which is delicate, and that one is also acceptable as per CDC recommendation. So for the waste disposal, all type of waste, including food waste from the patient room, should be placed in double plastic red bag and be treated as a highly contagious medical waste. All waste generated in Marburg virus patient room shall stay in the patient room and should not be stored in other holding area. When the medical waste transport arrives, environmental service will collect all the trash and directly to the medical truck. And the cleaning environmental service staff should wear level 3 PPE whenever they are cleaning the room or they are collecting the waste. So for the linen management, when handling soiled linen for patient, meticulous compliance with recommended PPE as I mentioned. All used linen, either disposable or textile, should be placed in double plastic medical waste bag and immediately disposed as highly contagious medical waste. So after the patient will be discharged, even this one is suspected or confirmed, the confirmed one, we are throwing all the bed sheets and everything that come in contact with the patient. But if the result of the test will be negative, it will be kept in the red bag and delivered to laundry for recycling. Only confirmed cases we are throwing the linen, but it's up to your management how they will deal with the linen if they want to dispose or to recycle it. So here is the important part of the presentation. We have this level 4 PPE. We have to use level 4 PPE in all cases of hemorrhagic fever. So what items we have to prepare if we will receive the patient? So first, we have to change, the staff should change the scrub suit so the staff can be easily moved in and out of the patient freely. And also in our facility, we have this powered air purified respirator, the popper, which is Versaflow. And also we have to prepare the coverall. For the coverall, if your size is small, you have to use the next size, so it will be more comfortable for you to move around and give care to the patient. And also you have to have the hood, which is attached to the popper machine. And you should have also this high boots. And we created in our facility our own checklist for us to be guided what is the proper step in donning this PPE, and also for the doffing. And we have to use also these high risk gloves. If the you have to make double gloves, so the first glove should be your size and the next one will be bigger, so it will be easily for you to use or to put on. So all the sizes, it should be available in your unit. If so anytime that we will receive the patient, especially in ED, it's easily for the staff to get all the things. And we should have this portable hand sanitizer. Only in this kind of PPE we are allowing to use the alcohol based rub with the gloves. Other procedure, it's not acceptable, but with this PPE, every time we have to do hand rubbing with the gloves. And also we have to prepare the hospital approved wipes, and we have to prepare also 2 set of chair, which is you should label as clean and dirty chair. And also in our facility in SSMC, all our negative pressure room has anti-room, and we are doffing outside the anti-room, and the donning part will be done in outside the patient anti-room. So if your facility doesn't have anti-room, you should have a dedicated area where you can doff and don the PPE. You can label that one as red zone. So that one will be the dirty area, and the green zone will be the clean area where you can don the PPE properly. Then what is there is 2 kinds of we can use also here N95 if your facility doesn't have the popper machine, and that is the only replacement. Otherwise, we have also this level 3 PPE, all the same except for the N95 and goggles. So same thing, you have to have the checklist, and all the items that I mentioned before should be also prepared for the level 3 PPE. So with this one, I will share to you our video that we developed during the pandemic time, so to ensure that the staff is still competent and they can easily access this one in our shared folder. I will also share with you, if we have one patient in ED, for example, one of our colleague infection control will go down, and to make sure that everything will go smoothly and ensure that all the things that I mentioned is available, and also to ensure that the staff will go inside safely, and to doff the PPE also to minimize the contamination of the services. So I'll share with you the video. Just a second.
We couldn't hear the audio, Jennifer.
Just a second.
Jennifer, you can go to share sound or share voice.
Okay, just a second.
Protective equipment
Now you
the
can
most
hear?
effective way.
Yes.
The Centers for Disease
Yes.
Control gives us detailed guidance on this. Considering the type of personal protective equipment available, we have come up with different modules. Number one, how to assemble powered air purifying respirators. Number two, how to put on or don personal protective equipment. Number three, how to take off or doff personal protective equipment. The objective of this module is to offer training to keep up the competency of healthcare providers in donning and doffing of personal protective equipment. Thus, we could safely care for such patients. Hope you enjoy this training and we thank you for all you do for our patients. In this video, you will see how to set up the powered air purifying respirator or PAPR. This is turbo unit. The high efficiency filter or HE filter. The filter cover. The connecting tubing. The plastic liner for the connecting tubing. The head gear. The hood. Perform hand hygiene. Allow hands to dry. Put on a pair of gloves. Select your belt. Install the belt by threading it into the motor. Tighten the belt for a snug fit around your waist. Set up the high efficiency turbo unit. Place the high efficiency filter into the filter cover. Ensure the high efficiency filter label can be seen in the filter cover view window. Take the charged battery from the charging station. Press test to verify the charge. Align the battery correctly. Mount the battery to the turbo unit. A click sound will be heard. To turn on the turbo motor, press the power button on the top of the motor blower. Perform self-diagnostic. Connect the VersaFlow airflow indicator. Ensure the ball in the VersaFlow airflow indicator moves freely. Remove the airflow indicator. Select the approved breathing tube. Insert the breathing tube through the disposable cover. Insert the end of the breathing tube with the bayonet fitting into the parallel slots in the air outlets of the blower. Remove the gloves. Perform hand hygiene. Adjust the head suspension as per the employee head circumference. Insert the head suspension into the hood.
Hi, good morning. Today you are assigned for a patient wherein you are required to use level 4 personal protective equipment. Before we start, it's important that you change to scrub. Also remove any personal articles or jewelries. Ensure you have sufficient hydration and attend to restroom if needed. Remember, each step to be carefully followed in an unhurried manner. Inspect all your personal protective equipment. Coverall, shoe covers, powered air purifying respirator or popper, hood with headgear, 2 pairs of long cuffed gloves. Perform hand hygiene. Allow hands to dry. Sit on a chair and put on full coverage of shoe covers. Perform hand hygiene. Put on the inner gloves. Wear coverall and pull on the head cover of the coverall. The inner gloves shall be tucked under the sleeves of the coverall. Put turbo around the waist. Fasten the belt around the waist. Connect the breathing tube to the head top. A click sound will be heard. Fit the head top to the head. Power on the turbo unit. Put on the second pair of gloves. Cuff shall be pulled over the sleeves of the gown. Turn around so the observer will inspect to verify all areas of the body are well covered. Make some range of motion to see the person can move freely and comfortably. Before you will move out of the patient's room, you will need to do certain important things. Observe for any visible contamination of the personal protective equipment. Get the attention of the trained observer. Once she signals you OK, you enter the doffing area. The trained observer will assist you in doffing and read out the steps clearly. Inspect, disinfect, and remove the outer gloves. Wear a new pair of outer gloves. Remove your head top. Bend over slightly. Pull head top away from the body. Hold the head top in the right hand. Disconnect the breathing tube from the head top. Remove head suspension from the hood. Keep the head suspension on the tray for decontamination, and then dispose the head top in the medical waste bin. Switch off the turbo unit. Unbuckle the waist belt of the turbo. Remove the breathing tube from the turbo unit. Keep the breathing tube and the turbo into the tray for decontamination. Perform hand hygiene. Remove outer gloves. Wear a new pair of outer gloves. Remove the coverall. Unzip. Pull it away from the body. Roll it inside out until the waist. Sit on a chair. Continue to roll it. Remove by only touching the inside of the coverall and discard it in the biomedical waste bin. Inspect and disinfect outer gloves. Carefully remove shoe covers by touching only inside and discard it in the biomedical waste bin. Perform hand hygiene. Remove outer pair of gloves. Disinfect the shoes by using approved disinfectant. Perform hand hygiene. Remove inner pair of gloves. Perform hand wash with soap and water. Turn around to observe or inspect any visible contamination of the scrub. Rehydrate as required.
So that's all for the video presentation. And thank you very much once again for inviting us here in the webinar.
Thank you so much. That was an excellent video and presentation. And thank you, Dr. Emmanuel. We have Tabrika now. We'll share a few words. Tabrika.
Hello.
Hello. Yes, we can hear you.
Good evening.
Evening.
Thank you so much, Dr. Emmanuel. Thank you so much, Jennifer, for coming to IPQ Academy webinar. It's a great pleasure to have you with us. It is like enlightening presentation, excellent information about Marburg virus that is really needed to learn about it more. Thank you so much. I just wanted to thank you for this amazing presentation, and the video is very professional, very informative. If you can share it with us, it will be a great help for our IBs who didn't attend today's webinar, not to lose this information. Thank you so much. And the platform is ready for a question. If anyone would like to ask a question, or it's fine.
Please feel free to open your mic or put your questions in the chat box. We can read it for Dr. and Jennifer.
So we have excellent feedback from the participant. Excellent.
So there is a question like, how can we isolate patients in clinical setting?
This is Dr. Emmanuel. I'm assuming that question is, when you say clinical setting, are you referring to being in, let's say, an emergency department in a clinical setting? Well, you do need ideally you need a negative pressure room. If you don't have one you don't have a negative pressure, and then a single side room will do, and maybe with a HEPA filter, as we do for COVID-19. But you should, within your health facility, especially within emergency department where patients with Marburg fever, Crimean Congo hemorrhagic fever, endemic in this part of the world, or Ebola from travel, likely to come through, you should have a designated, you should identify which part of your clinical area will be, your clinical setting or area will be the isolation room, and make sure that it is well prepared so that you're not making it up on the day when the potential patients arrive. And that is all the beauty of being prepared. It may not be ideal if you don't have a negative pressure room, but at least if you have a designated room, have a HEPA filter, you have all your PPE ready and people know where to get it. You also have signage already, then you are prepared, and that will minimize the risk in itself. The worst thing is not be prepared at all and making it up as when a potential patient arrives.
Thank you, doctor. And there is another question. So what is the percentage risk of acquiring Marburg here in the Middle East? Is there a higher or lower risk?
So it's not endemic in the Middle East. So you're not going to get Marburg in the Middle East just from living in the Middle East. It's only from people who have traveled to an endemic area and come back, either in the current situation because there's an outbreak already. The risk is still quite low because the outbreaks are within specific areas, and the government and WHO are in those areas in Guinea, Equatorial Guinea, and Tanzania controlling the outbreak. However, people who travel for tourism to West, East, Central Africa, where it's endemic, they're visiting caves or mines on holiday, and people do that quite on organized tours. If they come back and develop a febrile illness within 21 days, that risk exists. So the risk is low, but you need to be prepared because the risk is low, but the consequence is high if you have a patient that comes to your facility and is missed and not isolated, not identified, not isolated, and the right measures not taken. As I've said, if it happens in your health facility and not prepared, and your staff get exposed, you potentially can shut down your ED and your hospital if you have a lot of people exposed. So it's low risk because it's mainly travel, but if it happens and you're not prepared, you can easily be in a lot of trouble, and expose your staff unnecessarily.
So one more question, doctor. So the level 4 PPE is mandatory, or we can wear the coverall with a 90 respirator, because sometimes it's difficult to arrange level 4 in a small clinical setup. So
Very important question. I think, Jennifer, do you want to answer that, or do you want me to let you answer that?
Yeah, doctor, I will answer. As I mentioned in the slides, that we can replace the popper machine with the N95 and goggles. So, but we have to make sure that there is checklist that you will follow in donning and doffing the PPE, so we can reduce the exposure and make sure that the staff is safe going inside the room. Because we need to make sure that the patient is properly covered with the PPE, and that's all.
Another question is, while removing the PPE, once the headset is removed, since the person is not wearing mask, is there any chance to get infected while removing gown, to make the team understand? So basically the question is like, the person is not wearing a mask. So after they remove the hood, are there any risk of exposure?
There is a very minimal risk, but it's the recommended from the CDC, so it's already tried and tested, that what we call, but it's from the CDC, the steps also we are following. So this one is already proven that this one is low risk for the staff after removing the. That is also concerned by our staff, but it's also explained like it's very low risk because the patient, this one is airborne, so the one inside.
Okay. Any more questions? Okay.
Just going to add that the greatest risk, like most PPE, is with doffing. And if doffing is not done properly, as described by Jennifer, and hence why it's so important to have a checklist and somebody watching. You can also imagine that doing it also after looking after a patient with viral hemorrhagic fever. Often you may spend a lot of time there, and the patient may be agitated. So the most risk is from contamination of the PPE. Although there's a risk from airborne spread, it is less of a risk, more of contact with secretions. That is where the majority of the risk is. Hence why the doffing of PPE, especially the gown and gloves, is really where the risk really lies, and making sure that the person doesn't inadvertently touch their face because of they might be feeling uncomfortable, is where there tends to be a problem. Where there have been breaches in West Africa, where during the previous outbreak, it's been mainly with that. The point I'm making is in relation to the mask, is that the risk is very low. And the main issue is touching contaminated PPE with secretions rather than airborne.
Okay, thank you, Doctor. So last two questions. So one is about screening of patients. So how to screen? Like, is it screening all patients, or is there a triage?
So the way to do it, I think, would be to make sure travel history is embedded in your systems. So we're fortunate that we have an electronic patient record. And so as part of the triage for emergency department, all the patients are asked about travel. So if you come in ill with a runny nose, you'll be asked a question of, have you traveled? And if you said you have traveled, where to? And so right at the door, when patients coming in with an acute febrile illness, if you mention travel to these areas currently with Marburg, then you would immediately be taken to designated area for further assessment. So the key thing is having that built into your triage system, travel history. The second about a particular lab, I think it's a question about a particular lab. Yes, it's not it's only designated labs that will do a Marburg viral test, either PCR or antigen test via ELISA. And so you need to find out that's why it's important to plan, so that you know which lab in your region or country it does the tests. In ours in Abu Dhabi, it's a lab in Sheikh Khalifa Medical City. So you have to make sure you know where you may need to send samples to, so you're not making it up on the day if there's a suspected case. But there are only designated national reference labs that will do the test, because it's a rare illness, so no lab will invest in doing it as a regular test because it's not cost effective. Thank you.
So there is one question about waste management for these patients. So I think Jennifer addressed it. Do you want to say, Jennifer, answer this question? How is the waste management done in your facility for these patients?
So for the waste management, as I mentioned in the slide, if the patient is admitted in the facility, there will be timing where we can collect, and it will go directly to the truck. It's not the same as other patient that we can store in our storage area. For this particular cases, we have to make sure that the waste truck is there, and that's the only time that the porter will collect from the patient room directly to the truck, and the environmental service will wear the PPE, as I mentioned also.
So I think that's all the discussion is about. Thank you so much, Dr. Emmanuel and Jennifer. That was a really interesting presentation. And we really learned how important it is to know the travel history and be prepared with pathways and be prepared with keeping the staff up to date with competencies. That was really very insightful. Thank you so much for your time. Thank you so much for all the participants for staying till the last moment and asking your questions. It shows how much dedicated we as an IPR, and coordination is definitely important, and I hope we will make UAE best place to live. Thank you so much, everyone. Thank you.
Thank you and good night.
Thank you. Thank you.